Yes, Dr. Sudhir.
Yeah. Good evening, everyone. My slides are visible, ma'am?
Yes, yes.
First of all, thanks, AIVS, for organizing this meeting, and Dr. Namrata Sharma, Harbanslal sir, and Dr. Lalit and Dr. Rajesh. He just left, I think, because he's in travel mode. So thanks, Elargan, also for organizing this meeting. I think this is first of its kind after a long time in UP chapter. So without wasting time, today I'll share two talks. First is how to achieve quiet eye after cataract surgery, because it's very important topic, and nowadays we are talking about the quality cataract surgery, and in quality comfort of the patient and quietness of the eye is very important. And slides. Yeah. So in medical fraternity, no news means good news. So it is possible in two ways. Either the patient has run away because he's fed up from your job, and or the patient is very happy. Happy means the quiet eye, and patient is quite asymptomatic, and obviously patient will not disturb you. Any kind of surgery in the body can create a lot of structural and inflammatory changes. Similarly, in the eye, we get, conjunctival hyperemia, ciliary, circumciliary congestions, corneal epithelial erosions, corneal edema, antechamber reactions, and deposits on IOL. And so there are two very important aspects which needs to be, considered is whenever we talk about making the patients quite asymptomatic or making the eye quiet. First is to take the help of ocular surface, and second is to control the intraocular inflammations. So my talk will revolve around two points. So why this ocular surface is important, especially when we talk about the cataract, because if we compare the cornea, eye, and the camera, both have similarities. And for a crisp and clear picture, we need to have a clear lens for the camera, and for the eye, we need to have a crisp and clear, shiny cornea. And cornea, the main enemy of the cornea is the dry eyes and the ocular surface, bad ocular surface. It give a lot of irritation, discomfort, and stinging sensations. Patient comes quite often in the post-ops because of these problems. So understanding about the dry eye is very important. Why it is important? Because if we look at the prevalence of this problem in globally, it is 5 to 30% of patients are having some kind of ocular surface problem. And in India, it is around 20 to 40%. It means every second patient coming in the in the hospitals, they have some kind of ocular problems. And regarding the economic burdens, unfortunately, we don't have Indian data, but US data says approximately 3.5 billions of means dollars US healthcare spends to maintain the ocular surface, and it comes around approximately $11,000 per patient. So it's a huge economical burden on patients. Similarly, we can understand, because we don't have data for India, but we have this kind of burden. And if we go under the classification of dry eyes, then basically due to is important classification, and basically we achieve whether the patient is aqueous deficient or evaporative dry eye, and majority of the patients have mixed kind of picture. So asking these triage questionnaires, or using questionnaires and risk factor analysis and different diagnostic tools, which we discuss in the next few slides, what we basically achieve. We achieve to understand about the bad ocular surface. So diagnostic sequences we have to modulate, and fortunately we can divide it in two parts. One is non-mandatory test, and second is mandatory test. Mandatory test we can do easily at our clinics. I think every clinic has these things, and if we are not using it, we must use it, like fluorescent staining or different kind of stains, rose bengal or leishman green stain, to just understand about the conjunctival surface and corneal surface. Schirmer's test to understand about the aqueous production, and meibography to know about the health of the meibobin gland. Non-mandatory tests like MMP9 test to understand about the inflammation, then other invasive tests where we need certain documentation. They are not mandatory. But if you have, you can easily do documentation on the basis of by using these tools. Now we are majority of surgeons are doing practice at different centers, and even the corneal surgeon, they are visiting to different centers. So we can easily make, not even the only corneal surgeon, even the cataract surgeon can make a dry eye kind of kit, keeping the questionnaires and different kind of stains, and if possible, you can keep MMP9 kits to evaluate the inflammation and so on. So you can at least judge the your patient and about the ocular surface pre-operatively, and even not only in the cataract surgery, but it also helps in the refractive surgery. So different questionnaires, when we ask why they are required, because we have to do documentation. Certain patients may have certain, if you do a slit lamp examination, you won't find any findings, but they will tell about huge means numerous complaints they will say in the clinic. So you have to do documentation, and you can assess the effect of quality of life also on the basis of these questionnaires, because it is important to maintain it. Do the documentation. Regarding the important diagnostic tools is obviously the staining. Staining, one precaution is that do not use any viscous, like we use any kind of lubricant eye drops, because the lubricants they have uh, mucus agents, and you may get altered staining. So always use any simple antibiotic eye drop to dissolve the stains, and other stains like Leishman green and rose bengal, you can analyze the conjunctival surface, and Shermer's is very standardized now. So here again, one point is that don't touch the tip of Shermer's, because the oil present in your fingers can alter the readings. These things are very smaller things, but it matters a lot in a regular practice. So what we achieve after the questionnaires and assessing the quality of life and doing stains and assessing the tear film breakup time and doing Shermer's analysis, basically we only assess the effect of dry eye, not the cause of dry eye. Because, and as we get the bad ocular surface, we start lubricant eye drop. This is not a right way. So we need to understand about the cause also, because some patients of rheumatoid arthritis and the patient with MGT, they may have similar kind of Shermer's picture. So whether you'll give the same kind of treatment in all patients, it is not true. So you have to know the root of the cause, and through if you want to know the root of the cause, then you must understand the pathogenesis of the disease. So tear film instability and hyperosmolarity, like regarding the inflammation and the corneal and surface damage. Osmolarity is obviously high. When we see any bad ocular surface, you'll get a lot of floating objects because of the high concentration of the tear film. But if you several studies have already proven that you'll get the similar kind of osmolarity in dry eye patients and the normal patients. So with this assessing the osmolarity, after assessing the osmolarity, you cannot judge whether the patient has actual normal kind of problem or the dry eye problem, but it will definitely give a clue. Several solutes are there in the lubricant eye drop, like glycerol, erythritol, and L-carnitine. And glycerol enters in the cell very fast. It leaves the cell very fast. Erythritol enters very fast, but it leaves the cell slowly. And similarly, L-carnitine, which needs the active transport, it enters in the cell slowly and it leaves the cell gradually. So we need to have a combination of solutes to make a good lubricant eye drop. Regarding that inflammation, I'm not going in detail. It's a complex theory, but a word about the white inflammation, because some patients may come without any redness and without any signs, but they may have a lot of symptoms. So we have to be very cautious in those patients also. If you have MMP9 excess, then do MMP9 analysis, because it indicates the inflammation. If patient has inflammation, then right from starting, you can start the cyclosporin or any steroidal eye drop along with the artificial eye drops. And if MMP9 is negative, it means the only artificial tears will work. So if patient has inflammatory symptoms, then we can start Restasis or cyclosporin eye drops or tacrolimus. but the effect comes very slow. So that is why we need a combination of lubricants and steroid along with these medicine, because it takes months to show the effect on the ocular surface. Tear film instability is because of the meibomian problems, and now it is overdiagnosed problem, and previously it was not less diagnosed. So for that we need to understand, we have to examine the slit lamp, do thorough slit lamp examination to analyze about the blepharitis, or yes, see the meibomian orifices and other things. If patient has a problem, then you can just invert the lid and you can see under uh, any kind of autoref, you can see the under the infrared light, you can assess the presence and absence of meibomian gland, because presence and absence of glands are very important. And if the glands are present, then you can simply give hot compresses, massages, and pulsative therapies, and some oral omega fatty acids and other things. So regarding machines are not important. I'm not advocating that every clinic must have, but obviously if have access to this thing, like we have a keratograph. So with these equipments, we can do documentation, and the documentation definitely helps in your long-term practice. So what would be the strategy would be just to supplement the tears, like, and increase the tear film secretions and preservation. Supplements like is absolutely misnomer, because there is no a tear substitute is available, because ideal lubricants, they must be preservative free. They must have water, salts, and hydrocarbons, proteins, and lipids, and the long surface retention time. Osmolarity should be low, pH should be neutral or slightly alkaline, and they must be biological active, but none exist. So it's a illusion. So our lubricants have preservatives, electrolytes, viscosity agents, and osmolarity agents. So different kind of, different problems we need a different kind of lubricants. Viscosity agents, I'm not going in detail because it's a full class, but preservative is the big problem. DK is the most, versatile villain. Now we have fluorides. They are quite surface friendly. So the common complaints after cataract surgery is ocular discomfort, irritation, red eyes, and foreign body sensations, and the fatigue. And quiet eye it means that we need to have a corneal integrity. The cornea must be crisp and clear. There must not be any redness. Patient should have less complaints, less irritation, and modern surgery requires, in modern surgery, if we want to achieve a good results, then we need to have clear, less of reactions, because any kind of deposits on the IOL can hamper the quality of, optical outcome. Because we are we are talking about the premium IOLs, we are talking about the multifocal IOLs. So any kind of deposits definitely will hamper the outcome. So this we can achieve by putting non-steroidal anti-inflammatory drugs and the surface, keeping the surface normal. But again, if we use any kind of medicine, we have to use preservatives. So we need to have preservative-free medications, which not only take care of the ocular surface, but it also reduces the intraocular inflammation. So what are the alternative? Is the fluoride is the answer, because it's Allergan talk. So Allergan has a sponsor. So I must say, but it's a good thing. Fluoride is ocular surface friendly. It has bactericidal, fungicidal properties also, and it is very less toxic according to the several studies. So important tips to achieve satisfied and happy patients in the post-op. CCC is not the circular curvilinear axis. It is basically conversation. Always discuss with the patient, tell about the surface quality, tell about the problem, whatever the patient has, can correct them, do the proper counseling, take the proper consent. And if patient is having bad surface, then you must understand that you may get wrong calculations on biometry. Then again, patient in the post-op will show poor healing, and the patient will be quite symptomatic. And you must be aware about the patient status, general status like diabetes and retinal vascular problems. If the patient is on glaucoma medication, then because of the long-term use of medicines, patient may have bad surface. So if patient is diabetic and retinal vascular problem, then you have to control the, you have to minimize the chances of cystoid macular edema and the macular edema in the post-op. So you have to start non-steroidal anti-inflammatory drugs at least to couple of weeks prior. Just to summarize, achieving quiet eye is after cataract surgery is very, very important, and topical NSAID is very important to control the inflammation along with the steroids to achieve quiet eye. However, the preservatives, they are present in the topical formulations, can create problems, and BAK is is the biggest villain. Fluoride is the novel alternative alternative for the chemical preservatives, and fluoride is found to cause minimal effects on the corneal surface. So if we control the surface, if we polish the surface, if we keep the ocular surface well maintained, glistening corneal surface, and if we control the intraocular inflammation with all these things, then definitely we'll achieve quiet eye. Thank you very much.